Hello, everyone, and thank you for joining. This is Dr. El Abbasi from 3D Diagnostics, and I would like to welcome you to the 3DX series of education webinars. And I'd also like to wish you and all your loved ones all the best in health and wellness. Now, a few technical points regarding today's session. A code will be given at the end of today's lecture for CE credit, along with the details required to claim it and the website to claim your CE credit. Moreover, an email will be sent to all attendees within a few days with a CE certificate. Also, please feel free to add any question you would like to ask in the Q&A box, and it will be answered either by one of the panelists during the session or by Dr. Engel at the end of the session. Any unanswered question will be answered by Dr. Engel and sent to you by email within a few days. Moreover, please visit shop.3ddx.com or our website 3ddx.com for ordering PPE and N95 masks. So, that being said, today's webinar's title is Dentistry's Digital Influencer, and we are so fortunate to have our presenter today, the founder and president of the Engel Institute, diplomat of the ICUI, a pioneer in education of implant dentistry, one of the most knowledgeable and super GPs in the field, and frankly, my personal mentor, Dr. Todd Engel.
Hello, thank you so much, Frank. Hello, everybody. Welcome to tonight's event. I hope that you guys are all well wherever you are in the country or the world. I know that we've all been through a tough challenge and a trying time, and with that being said, I think we're all feeling the last turn at the last corner. I've been back to work now for about a week and a half, and it certainly feels good. But nevertheless, the general position tonight will be happy, and it will be one of planning a comeback. I'm really excited about this piece tonight. It's brand new material. I do, as some of you may know, quite a bit of lecturing. I've done quite a bit of webinars. And I just really enjoy this one, as I do all of them, but I enjoy this one because I think it challenged me, not only as a dentist, but also as an educator, to try to see what the new was. Like, what is the next wave for us? What is the next way for us to be successful? And this has been a very interesting time. Obviously, it's affected everybody differently. For me, I took it as a challenge, and it was very positive, actually. The good thing about it, you know, I obviously didn't like what it did to people, but I loved what it did to humanity and making us all believe that we should value things differently. Friendships, restaurants, our jobs, just a baseball field, right? And so from that side of things, I think it was really good in a strange kind of a way, but it also challenged me, I can tell you, to just think differently, be proactive in different ways, and figure out a new niche on the way to be a dentist. You know, we've all been affected. This is the first time in our lifetime that everybody's been affected together, and there's no answers. It's not London, it's not New York, it's not Egypt, it's the world. And we're all coming out of this together, and it's going to be an interesting time. So while we certainly will talk a little bit about dentistry, I think tonight's piece for me is more about what does the next wave, so to speak, look like? And so tonight, we're going to talk about the digital influencer, and I think it's important to start with a couple things. First of all, Khalid and Frank and everybody at 3DDX, thank you so much for asking me to speak tonight. It's my pleasure. As you guys know, we've done this for many years together. All of you who are watching, thank you as well. It is my honor and privilege to bring this to you tonight. I do want to mention that there's no financial remuneration, that I'm doing this because I want to, and I want to support 3DDX, and I'd like to see if I can help support you also. So that being said, I'm going to share some opinions that are mine. And I think that there's so many different ways to approach almost everything that we do that I certainly don't believe my way is the only way. It just typically works for me. And I'm a GP, and I'll get into that in a little bit. I've trained myself in surgery. My practice is limited to surgery at this point, and we'll get into that in a little bit. You know, I think now as we get into the next phase of our professional lives, things are going to change. We are going to hit forks in the road, and I'm going to talk about that. I'm going to talk about what I believe is in front of us, and I'm going to talk about where we were 2 or 3 weeks ago, the uncertainty of that, where we are right now, feeling the end is near. It's almost like the child's almost born. Come on, let's get this over with already, kind of thing. But I think that tonight's title is really, really important. And it's important for me as an educator, and it's important for you as professionals, regardless if you're speaking to your patients or your family members, your loved ones or whatever. I love the word influencer because to me, that word means that you have the ability, when used correctly, to change somebody's life, and you have an influence on them. So when we talk about an influencer, we talk about, the description says one who exerts influence, right? A person who inspires or guides the action of others. So how do we do that now? What can we do to be a better influencer to our patients with all of these things that we're now challenged with? And we're going to talk about some of those things. Now, it's really important that that you understand that when I say influencer, I'm not talking about getting them to spend money. Now, if you look on in the dictionary and you look up this word, it's going to largely talk about how you influence people to spend money. And it's because it's very vanilla, if you will. For me, it's more of how can you influence someone to have hope? How can you influence someone to feel comfortable about making a decision as a patient when you know, all of you know, that there's a lot of people who just don't know how to do that, whether it's fear, whether it's neglect, whatever it is, they just don't know how. And it's typically the person that they're talking to that engages them to proceed. It's really not price, and it's really not your margins or how straight your implants are. They have to feel like they believe you. They have to feel like they're comfortable with you. And if they feel this way, then everything that you tell them will influence them, right? So I hope that I can help influence you tonight to think a little bit outside the box, and that's my job. So that being said, I really hope that you enjoy the evening. Okay. I love communicating with you guys. I have done this for many years. This is my 17th or 18th year. And I get lots of emails. I get lots of people that call my office, et cetera, et cetera. And I want you to know that I'm happy to talk to all of you. And the reason I'm putting this up is not to become more popular. It's just to let you know that I put a lot of really cool things on Instagram. I just started like 3 months ago, and we've built a nice little following because there's really good stuff there. There's some really cool stuff. When I present stuff on Instagram, it's to share a learn. In fact, if you look at all of the things that are posted, at the very end, it'll say, here's the learn. And it talks about those things that are the bridge between maybe having a failure and then turning it around. What is that bridge? What do you need to look at based on what you just saw happen? So anyway, and you can also direct message me if you would like to there, and I'm happy to communicate with you. It's the easiest way. So you can go and jump on that site and follow me, and I'd be happy to follow you back and talk to you that way. We also have an institute site on Facebook if that interests you as well. And again, this is not a plug to become more popular. It's just a way for you to follow some cool stuff if you want to. Okay? All right. So, you know, the current climate, you know, we look at this, this virus, and it has disrupted all of our lives in so many different ways. And, you know, from a month ago to 2 weeks ago to even now, it's interesting speaking to you because I know that a lot of you went back to work, and I know a lot of you haven't. Michigan and New York and New Jersey and several other states are still closed. Oregon is still closed, and there's some other states that are as well. So it's interesting talking a little bit about a hybrid. It's like some of us have dove in the pool and others are not. We're, still standing on the edge. But nevertheless, I think that whether you're in the pool or on the edge of the pool, you get the feeling because you're involved. So the current climate of where we are, there's three very, very influential, strong categories. Number one, what are some of the considerations that you as doctors are going through, or me as a doctor are going through? What are some of the things that we're concerned about or considering right now, right? Then you have the patient considerations, and we're going to talk about these. What considerations do the patients have? I want to share this with you for those of you who haven't gone back to work yet. I've been extremely, extremely pleased with my patient load, how it returned to normal inside of a week. And not only did it return to normal, but from what I've seen, most patients, are unaffected. They realize that we're going to take precautions to keep them safe. We've done certain things without going overboard, truly. We've done certain things to show them that their health and their safety is very important to us. And we could talk about that later. And if you want to ask me, you can on Instagram, and I'll be happy to share whatever you'd like that I'm doing. And then lastly, at the same time, you as the professional, you have to think about practice considerations, right? So number one, what's happening with you as the professional? What's happening with your family that relies on you to be the dad or the wife or the sister or the mother, the caregiver? What is happening with the people who depend on you? I feed a lot of people, and I'm sure you all do too. So what's happening with that? What's happening with your patients, and what's happening with the practice? Well, let's look at these things. So let's start with us. What are some of the immediate considerations that you have? Well, I'll tell you. One is the SBA loans. Did you get your loans? Did you not get your loans? Did you get your PPP loans? Has it been 40 days? Are you now preparing to pay back the loan, right? Loans. That is heavily on your mind, whether you're waiting for it, you're just about to get the second round, or you have to now exert all this time on repayment, right? The next thing is, for those of you who aren't open yet, or just open, like, when am I opening? Like, when is my practice going to open? And if I open Monday, what is that going to be like, right? And then lastly, what's going to happen when you go back to your staff? Some of you have furloughed. Some of you have fired. Some of you have laid off. What's going to happen when you go back? How is your staff going to operate, right? So one of the things that I said in some of the webinars that I've been asked to do is, they say, hey, Dr. Engel, what is your opinion on when we go back? And I said, well, my opinion is this. We have been off for 2 months plus. As professionals, we enjoy learning, me included. So what do a lot of us do? We've spent these last 2 months, most of us, in webinars, right? We've been learning all of these new things relative to our skill set. So I said, so what's going to happen is you're going to go back. You're going to be out of training, right? Because it's like going to the gym for however long and then stopping for 2 months. When you go back at day 61, you can't lift the same or run the same. You need to build back up to it. So we go back to the practice. The rhythm and the cadence isn't there. Everybody's kind of like out of sorts, if you will. And we're throwing in all these new procedures that we've never done before that we learned on the break. Crown lengthening, connective tissue grafts, maybe, full arch implantology, whatever it may be. And this is going to be a disruption. So my recommendation when you go back with your teams is, this is what we did. The first week was a 10 to 4, 4 days. That's it. I wanted to get back into the rhythm without burning my staff out. The second thing that I've been advising is, when you go back, do your bread and butter dentistry. It will behoove you to do this. Do not dive into a bunch of new procedures because you're excited about them and they might be dollar producing, because the cadence will be worse. So go back and do, for the first week or so, what you're very used to doing and get that rhythm back. Then throw in new stuff. And then the next thing is, what about the PP&Es? Like, none of us know when we go back what that looks like. And I'll tell you something scary. What if you are demanded to operate a certain way and you can't get what you need? I mean, have you ever thought about that? Have you ever thought about being mandated to have something on your face that you can't get because everybody else in the world is trying to get it, right? What do? Do you not work? This is a big consideration, okay? All right, so now when we talk about the patient considerations, and we're gonna get into more of this, and I'm gonna share something with you that I'm very excited about. When we talk about the patient considerations, this is very interesting, okay? This was a couple weeks back, or now a month back, all right? Now, keep in mind, on April 17th, 2020, this was the beach in Florida when it opened, okay? There were people like very intimately close to another, and this was before we even quote unquote went back. Now, I want to give you my position here, much like politics and religion. I don't have an opinion on this. I don't have an opinion. I'm just sharing something with you that's factual, okay? So whether I believe that people should go to the beach or not, I'm not emphasizing that right here. I'm just showing you what has happened. Okay, now on that same day, now mind you, we were still closed. There was no phase one, there was no anything. They opened the beaches. Now mind you, on that very same day, walking distance away was this. And what this was a place where people would go to get tested for COVID. Now I'm telling you, these were 2 blocks away from each other in Florida. This was walking distance. So within 2 weeks, you had people that had an opinion that it was okay to walk on a beach with each other, with strangers. And again, I'm not saying that's right or wrong. Now, 2 blocks away, at that very same time, in that very same state, in that very same zip code, and a few blocks away, you had these people dressed up, head to toe in PPEs, examining people for COVID. So my point here is this. You don't really know what to expect from your patients. You have no idea what to expect, because if you operate very gingerly and you take this maybe half-heartedly, you might lose some of those patients that are in this image right now, that feel that you are not abiding to what you need to abide to keep them safe. Yet maybe the people that went to the beach would have no problem with anything that you did in the practice because they just don't believe it's real. So there's a lot of things that we're in control of, but there's some things that we're not. And the hard part is that the patients control your revenue. So my point here is don't be too concerned about being overly cautious. So if you buy your N95s and you buy your face shields and you buy, your disposable gowns or whatever, and you're constantly changing them, and you have certain things, we have booty covers in my surgical suites. We have the patients step in the booty covers and then go into the suite and then trash them on the way out. That beach goer won't mind that. But on the flip side, if you don't, let's just say, dress up, you can lose a lot of your revenue by people who believe that you should be dressed up. Okay, and that's for you to decide, but it certainly is a consideration, right? And we'll come back to this. Okay, now what you're looking at here is life as we knew it, March 10th, 9th, 8th, 7th, right? So you're looking at us, on the left, this is how I would do my exams. I would have my mask down. I would talk to them. I would want them to see my face because, I would want them to know that I was inviting and that they can speak to me and I'll be their friend. At the same time, I'll be articulate about dentistry, right? You're up on them. You're up on them. The image far right with the 2 gentlemen. I mean, he's got his hand on his shoulder and he doesn't have anything on his face and they're chatting away, right? But COVID has changed all this, okay? We may not ever see that again. So how much do we go to the right to prepare for this? And that's going to be a decision you're going to have to make. But I'm going to share a few things with you that I think will inherently help you, and it could be quite fun as well. I want to introduce a term that yes, I came up with, called professional distancing. And I was thinking about this and, this whole social distancing thing. when you think about it, people are staying away from each other in a restaurant, or, you know, we can't even get our hair cut right now. Look at me, right? And yet when we talk about the practice, and we're literally, we in our practice have 3 out of the top 5 most dangerous professions as it relates to people and working around the COVID situation. And, you know, we are going to work and we have to protect ourselves. So what do I mean by professional distancing? Well, let's look at this. We are going to be going into a different chapter and realm of dentistry. It will happen. It is going to happen. And I'm going to start by telling you this. Digital dentistry has been around for a long time. Guided surgery has been around for almost 18 or 19 years now. I actually was one of the very first ones in California to do one about 17 years ago, full arch. So this is nothing new, okay? But I will tell you that more than ever, people are going to be leaning on not only guided surgery, but eventually robotics. Because what we have to do is we have to eventually be able to treat patients with less intimacy. It's got to happen. And if we don't follow that trend that others are doing, we may lose our patients to some of those people. So robotics is still a ways away for a lot of reasons. There are a lot of people that are dabbling in it. I'm actually playing with it now. But digital dentistry and guided dentistry is here. It's been here. It's nothing new. It's going to become more prevalent. And we're going to show you why. Okay, so we're going to discuss care that is hands off. How can we do this excellent, amazing work for our patients that we love to do, but be more hands off in nature? Okay, so let's go back to the patient again, and we're going to revisit this. Okay, so going into this new chapter of our professional lives, we're going to have demands set upon us. You can trust this. Maybe not by the legislation, but by each other. Because there are things that I know that I can do with less visits, less time, etc., with the patients that will support this whole COVID stay away from your patient as much as possible theme. And if I'm doing it and others are doing it, you have to do it. You're going to have to do it, because I think that that's going to be, in my opinion, the second wave. I'm not so concerned at the moment about figuring out the COVID second wave, because that's not my job. But I feel that the second wave as professionals in our arena and platform of dentistry, I think it's going to all be centered around how we change. And if we don't change, this could mean trouble. So less visits. What does that mean? For sure, more planning without the patient. Less touching, less looking, less saliva, less all of that. If we can stare at a screen and we can spin a head around and we can grab things virtually and put them where we want them, like Invisalign, for example, that is going to be on the rise. There's no question. Next, we're going to be asked to create shorter appointments. So how do we have less visits and shorter appointments and still make money? Let's be real. I'm going to be real with you. How do we make money? How do we make money? How do we make money and still provide insane care? I like to provide insane care. I want to be a Four Seasons kind of dentist, right? Where, meaning I demand a lot of my own talent. That's just the way that I am, whether someone's watching me or not. So how can I still do that with less visits and shorter appointments? And how are my appointments shorter? Well, you have to prep a lot without the patient. Yes, and it's possible, and I'm going to show you. And then lastly, less patient interaction. And so what does that mean? That means less time when they're sitting there. And I'm going to show you that as well. And that means, without question, technology. Without question, that's where we are, that's where we have been, and that's where we're going to have a boom. Okay. So I want to introduce you to something that I think it's the first time you've heard it, that I came up with. And I want to talk about an 11-minute appointment. Okay. Now, I don't have any DVDs for sale. Okay, I'm not selling any books. I'm not selling anything. I'm just telling you what I feel. Okay, so how do we do an 11-minute appointment? Now, keep in mind, what I'm going to be talking about now is treatment appointments. I'm not talking about a new patient hygiene appointment where you get your periodontal readings and all this stuff. That that has to go unchanged. There's certain documents that we need, information that we need, documentation that we need to baseline our patient, okay? And we'll work on that too. But what I'm talking about today is I'm talking about when it comes down to doing care, okay? When it comes down to providing treatment. I'm gonna show you some pretty amazing things at the end of this lecture that were done in 2 appointments, okay? All right, so what do I mean by an 11-minute appointment? Now stay with me and let's assume for a moment, okay? Let's assume for a moment, bear with me, that budget's not an issue, okay? Let's assume that we will just get what we need within reason. I mean, I'm not gonna suggest a $250,000 piece of machinery. I'm saying within reason, let's assume that, okay, we're willing to invest a little bit of money in ourselves and our practice to stay awake. Okay, so I wanna share this 11-minute appointment with you. How do we do this? Well, first of all, we start with photos. So if you don't have the acumen to take some photos, learn. That's all I can say. Learn the basics about taking dental photos. 6, 8 images, that's all you need. Take some photos, a smile, a rest, a relaxed, a profile, a couple of occlusals, whatever. Photos, 5 minutes. Okay, you should be able to take 6 to 8 images inside of 5 minutes. Next, an intraoral scan, 5 minutes. Now, I'm not selling anything. I don't own a company that sells scanners, okay? I'm just giving it to you, friend to friend, pro to pro. You should definitely put your sights on an intraoral scanner, and I'm gonna tell you why. Number one, it is far easier for you and your entire team to go through an arch or 2 arches in 5 minutes that doesn't require impression material, that doesn't require a pour up, that doesn't require saliva, that doesn't require decontamination and bagging and everything. And if something happens where the tooth breaks or filling chips or whatever, that essentially is no good anymore. Whereas an intraoral scan is a file, an STL file, that if the patient goes unchanged, you can use it 12 million times without touching the patient, okay? If this is new technology to you, get used to it because it's not that hard. It's taking a picture with a microphone instead of a camera, okay? And now technology is so robust and bold that it could do a lot of things for you, including shade matching, contours. It could do, you guys know, you've seen this before. This is nothing new. But what is new is that we have to get into a direction where we can get more for less. And I'm not talking about money. If I can take a 5-minute scan and have this data, this file, to use as many times as I want, and my assistant or my team doesn't have to go in the patient's mouth more than once at 5 minutes, this is a big win. And the patients are gonna like this too. And then lastly, a CBCT scan, 1 minute, okay? I'm talking about actual, put the patient in, adjust their chin, hit the thing between 6 and 20 seconds and game over, okay? And then you dismiss the patient. And you may be saying, well, how's this possible? I'm gonna show you. Okay, so you should be thinking to yourself, if you're looking at 1, 2, 3, you should be thinking, well, okay, I can handle the photo thing. Okay, I have an intraoral scanner, or I don't have an intraoral scanner, but I've been meaning to look at one, and that's probably a direction I would go. And maybe more than half of you don't have CBCT machines, and that's okay. I do feel that that's something that we need to feast our eyes on and eventually look into that technology for a lot of reasons. But you can always send your patient to a lab for $300, or you can have a mobile service come over. So I'm talking about the 11 minutes of what needs to happen. I'm not telling you that you should go spend $125,000 on a CBCT machine, even though I feel that personally that everyone should get one eventually, because that's where dentistry is, right? And I'm sure most of you have them, or if you don't have them, you've thought about having them. So now this is the data that we get for 11 minutes, in 11 minutes. Okay, now what you're looking at now is a Zoom meeting, okay? I did this meeting, I don't know, last month with a team of people, and we now, it's tele everything, as it says. Everybody's doing the tele. You're on right now with me. I'm on right now with you. This was not something that was nearly as common 3 months ago as it is right now. So what I'm going to suggest to you at this point is go take all your data, take your photos, take your scan, take your CBCT, and turn this into tele-dentistry. Okay? Now what you're going to do is you're going to schedule a time with your patient. You'll go to whatever site that you can go to, whether it's Zoom or GoToMeeting or whatever. You can even get one of the entities that are tele-dentistry. I recommend not, because they take a percentage usually, but you can get for Zoom for a nominal fee. You can have up to 100 people. Well, here's where you go with this. You schedule a time with your patient, that patient that was in your office for 11, 12, 13 minutes, and you tell them, listen, what we're going to do is we're going to allow you to go home, think about this, and we're going to meet tonight 7 o'clock, if that's okay with you. And I'd like you to have your significant other there, or anyone that might want to hear that as well. And it's going to give me a little time to get all of this information together, to get your scans together, to get my thought processes in order. And I'm going to sit with you. And I'm going to sit and I'm going to answer as many questions as you would like, just like we were chairside. But I would like your husband or your wife or your sister, your mother, whoever else with you. Now, guys, this is me with you. Imagine a patient being in their living room like I am here, and sitting with their significant other in the confines of their own home, where they're very relaxed and very comfortable, listening to you one-on-one with them, like I'm doing now with you. And I heard any question that you would have. Hey, Dr. Engel, what is that up there? Oh, that is your mental foramen, right? And so we take the time that we used to have in the office with 40 to 50 minutes with a patient, or however long you would take, depending on how complex the treatment was. And we're just taking it from chairside, which most patients really aren't comfortable anyway. And lots of times they are assessing you as an individual. And now we put them in the confines of their own home, in their own living room, in their familiar surroundings. They feel more comfortable about making a decision. Yeah, this might be weird at the beginning, and you might feel, well, I'm the kind of person that feels that the arm rub or the shoulder tap or being with them right there makes them like me. Well, you're preaching to the choir. I like being with people. I would much prefer to be in a room with you right now than speaking over a computer. But life is different, at least for now, right? So I want you to think about this, because you're actually going to be more productive in your practice, and you're going to not only keep your patients safe, but you safe, you and your team. And this could all be for naught, guys. This could all be for naught. This could be something crazy when it turns out at the end, but we don't know. Okay, right now we just don't know. But let's keep going, and let's talk about how this is going to work out. Okay, so a little bit of just really quickly about me. I'm Todd Engel, and I started what's known as the Engel Institute about 17 years ago, and I train all levels of dentists, GPs. I've had specialists come in various modules of implant dentistry. I'm a GP. I've done thousands and thousands of implants, and I just say that because I buried my brain in it for a lot of years. I learned a lot about bone, teeth, and gums, and now my practice as a GP is limited to full arch implant surgery, and I restore my own cases. The reason I'm bringing this up right now is because I love to inspire people to do what I do, and that is what I love to do. It is a gift that I'm blessed with, that I'm able to help and see others do well. And to date, we've trained about 12,000 dentists. But most importantly, the reason I'm showing you this image, because I'm not the kind of person that's going to, talk about all my accolades and diplomat this and diplomat that. I'm just Todd. okay? The reason I bring this up now is because I think it's really important, again, as I mentioned early when we started, I think it's very important to inspire people. And it feels great. And you are meant to inspire somebody. You are. And you are meant to not only inspire whoever you do in your personal life, but you're meant to inspire your patients. They want to be inspired by you. And that is the connection. It really is. So that being said, when I think about what I'm talking about to you right now, I think about a few things. One, what are some of the products that I use? Because I want to make sure that I'm comfortable with my products that I use and that I feel that they can continuously give me the results that I'm looking for. Two, I look at the companies that I'm involved with. I happen to be sponsored by Straumann, and I know that that's a gorgeous company that is going to be around for many, many, many years, and they're very strong, and I can count on them for technology, and I can count on them for R&D and all that stuff. So I feel very comfortable, right, with, as an example, Straumann. And lastly, I'm a people person, in case you can't tell, and I surround myself, or try to, with good people. And I think that when you can look at product and company and people, that's a good combination. And for you, it's the same thing. When your patients can look at you and say, you are their product, you have that company, and you have the people, I think that you can really inspire your patients to elect to do what you tell them that you think they should do. And that's it's very important. I don't want to sell anyone into anything. I want them to believe that that they have chosen the best option for them through me, right? Okay, so let's talk about treatment. COVID part 2, I mentioned this, and this was very easy for us. We would walk down this path. We all did every day. A lot of us were selfish, including me, and we just took life for granted. And all of a sudden the world gets shut off. And we start, wait, no, I want to go to a football game. No, I want to watch soccer on TV. Wait, I want to go to work, or I want to go even for, a salad and a glass of wine at a restaurant. You can't. So what's happening now is, as we open, we're hitting this thing that you see in front of you. So this arrow is us, all right? And we can't walk straight anymore. We just can't. That is not an option for us. So one option is to go left. The other option is to go right. And who knows what's at the end? We don't know. But you have to choose an option, and you have to believe in that option, and you have to go. Staying the same, I feel, will be very dangerous to you and your office and your income. And I say that reluctantly, because I wish not, but I do feel that it's time that we all figure out a way to make ourselves and our practices different. And it's not so much that it's a competitive thing with each other as it is it's a competitive thing now with a patient, meaning if you don't have what you're supposed to have, they will not be as loyal. This is my opinion, because a lot of them are in fear right now. Okay, so when we talk about this inspiration and with the patients and what dentistry is going to look like when we get back, there's a few I words that I like to use, and I want to encourage you to use some of these. And then we're going to get into how does tele-dentistry float into treatment and care and being busy. Okay, so the first thing is interactive. Okay, without question, patients want to be interactive with you. Now think about this. Like, don't be so fast to say, well, I'm interactive. Okay, because just think about this and assume all of these things I'm saying are, for a moment, maybe a learn. Okay, so interactive. So what do I mean by that? Think about it. If a patient's sitting on their couch, or they're doing a tele-dentistry thing with you, even though you're not in the same room together, that is very, very, that is intimate, in the sense that, wow, I'm with my dentist. They're at home and I'm at home, and this is actually quite comfortable. They want you to be interactive. They want you to tell them their story. Okay, they want you to make it independent for them. Okay, the second thing. Oh, I'm sorry. I think I hit a bad button. Hopefully you guys can see me. Frank, I think we're okay, but text me if we're not. I think you guys can hear me. I accidentally hit a wrong button. Okay, number 2, you want to be informative. which again, you might say, well, I'm informative. But my question is this: do you feel that you could be more informative in 40 good minutes without a distraction of a phone call or someone telling you that the lab is trying to get you on the phone for a new impression, or there's a problem up front at the front office with a person who's raising hell because they don't feel they have a balance, and your hygienist needs you for a check? So are you informative if you're taking 20 minutes when you go back and you're hustling through? Hang on, it's Frank. We're good. Okay, perfect, thanks. How informative are you when you go back? Are you, when I went back last Monday, I mean, I've been doing this for a while and I only do 10 things. I do surgery, 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 and surgery, right? But when I went back, it was like I was going back to high school for the first time. I was nervous because I hadn't been in my practice for 9 weeks, right? And doing it every single day and then not going, you get a little anxiety, like, what's this gonna be like, right? So with all of this, are we gonna be informative or are we gonna be racing around and sidetracked? I think a tele-dental meeting is very informative and it's very relaxing to everybody, like me with you. The only thing I'm thinking of is speaking with you. I'm not thinking about my team because they're not here at my house with me, okay? Then the next thing is individualized. I said that when I was talking about interactive. Individualized. The more that you can individualize the share, the discussion to that individual listening to you, the more they're gonna feel like it's for them. Versus, well, you can do a root canal and you could do an extraction and a graft and then you can do an implant in 3 months. That's not individualized. It's just not. It's just something that we all reiterate at some point. So when I talk about being different and individualizing it, I'm talking about like showing them their scan on the screen, showing them maybe a guided surgery if you're doing implants. And I apologize, I don't know who you are. So if you are, great. If you're not, I'm sure you have an interest. Right? So if I can turn the person's skull and show them a pink implant right in the spot that they are missing their tooth, they know that I individualize this care for them and I'm sharing it. I'm not just sharing some random model of anyone that walks in my door, and they like that you've taken that time, okay? The next thing is investable. This means when you're done performing your excellence, do you think that they want to invest in you, right? I see 3 to 4 full mouth cases every day for consults. That's a big ticket. I have to make them feel the way they want to feel so they feel that I'm investable. If someone's going to drop $30 or $40 or $50,000, they have to look at me more than this guy's a nice guy. They have to look at me and feel like I like everything that he's telling me. I like how he spent time with me. I like how he showed me my plan. This is where I've decided to put my money in. And the bottom line, guys, is we work for a living, right? So we all need income. They have to feel like you are investable. Next, again, here's that word again. You have to inspire them. The more that they've neglected their mouth, the more that they've put it off, and we all have patience. Trust me, I see these people that are just gone, okay? Beyond neglect, okay? We have to inspire them to feel like, hey, it's okay. It's okay. My job is not to figure out why you are the way you are right now. My job is to help you be better, okay? So I want to inspire them like I want to inspire you to go do stuff to be better, to do better for you, to be more successful, because your success has no barrier on me or my life, meaning I want you to do well. Right? Some people don't wish that for others, and I'm not sure why. And then lastly, together, here's the 4-season service, okay? You have to deliver something to them, for them, that is special. And when they feel this, it's a win for everybody, okay? But there's a big piece here that we're gonna hit here in a minute that we haven't got to yet, and that is, can you, right? Can you? Being able to talk about something and being able to influence someone and inspire someone is one thing, but can you deliver the care, right? Let's talk about this. So just, as I was looking up this path, I came across this, and I think that it's really important if you have your phone or whatever. I think The boys can correct me if I'm wrong, but I believe that they're recording this and it'll be on YouTube and you could go watch it later. But these are really important pit stops, guys, and practice them, keep practicing them. And if you do them, great. If you're very good at them, fantastic. This is not meant to insult anybody. It's here to challenge you to be better. I want to be better. I want to continue to get better. And if we feel that we're as good as we can be, I think it's time to hang it up. Okay, so that being said, before we get into treatment, I love this line. Albert Einstein said, strive not to be a success, but rather a value. And I think that's basically it in a nutshell. If I'm of value to you, you will never, ever consider how much you've paid me. I never hear from people how much they came to my class and paid, because they're going out and I've given them a value. You give someone a fish, you teach someone to fish, you all have heard that. They go and they can't wait to get back to their practices to do what they know how to do now. That is a value. So be a value. Okay. All right. So let's get into the care now. Expert diagnostician. You may not have heard that term given to you before. It's nothing fancy, but many years ago, I kind of centered some of my discussion in my courses around being an expert diagnostician. And what do I mean by that? It means taking everything that I'm about to show you. So the first half of it was, think about the post-COVID thing, or the corner two of COVID, right? Now we're going to talk about how to use that information and care for and on people. So what do I mean by expert diagnostician? You know, I think dentistry would be a great place, which it is, but I think it would be better. I think that the surgeons would appreciate the GPs would appreciate the surgeons, and we do, and they do. I'm just saying, you know, how some feel that some shouldn't do certain things and what have you. But I think that if we were able, all of us, to accomplish what I'm about to tell you, I think that if you graduated dental school within the last 35 years, you would accept it. If it was more than that, you're probably stuck in your way. And whatever, it is what it is. So when I talk about being an expert diagnostician, I'm going to give you three things. I'm a man of threes. And if you can pull these three things off, and you can create value with these three things, you won't chase money. I promise you this. All right. Number one, understanding the patient. So when you look at a CBCT, when you look at periapicals, when you look at a panel, when you look in someone's mouths and you see striations, or you see the absence of keratinized attached tissue, or you see mucosa around teeth, like, do you feel that you understand the patient as a whole? Do you feel like you're seeing everything and you understand everything that you're looking at? Do you see calcifications on x-rays, or, you know, calcifications on cone beam, that you understand what they are? Every single time that I see something that's unique to me, I dive into, what is this? Okay, what is this? Whether it's a type of a drug someone's taking, or a calcification in someone's neck, whatever it is, because those are learns for you guys. And they're learns for me too. So do you understand the patient? Not only with the x-rays and what you see intraorally when you look in the mouth, but do you understand the personality of the patient? Because this is way overlooked, and this is a big deal. There, as we know, there's 4 distinct personalities. And if you don't speak to someone the way that they need to be spoken to, you can lose that patient just merely on that. So that's number one. It's collectively, do you understand everything about that patient? Number 2, can you translate options well? Now, think about this, guys, because this is a really good time for all of us to step back and say, maybe I don't do it that well, right? And if you do, that's great. I'm not here to say that you do or don't. I'm just here to challenge you to think. Do you see when someone needs a sinus lift? Do you see when there's inadequate bone? Do you see when there's, you know, migration of tissue on the mesial buccal root of number 30 on a natural tooth? And do you understand why, right? Can you translate options to patients? And I want to tell you that the number 3 is more attractive to anybody. And that's why Starbucks has 3 size coffees. The gas station has 3 prices on their sign. Jokes are typically A, B, and guess what? C, and then a punchline. Because we as humans, it's very well known that we are turned on by 3s. And this is proven in marketing to get people to relinquish money, actually. So when I do my treatment options, I do what's called a good, better, best treatment. And so if I were to going back to before, I would tell Lisa, I'm going to get together with you tonight at 7:00, and I'm going to provide you, I want you to think about this. I'm going to provide you a good, a better, and a best treatment. And you decide what you want to do. And it'll be based on budget, really. It will be just like a condo, a single family home, or a large home, right? It's basically budget. We would all, we'd all like the best of everything, but it's budget dictated, and this I know. So number one is, do you see everything? Number two, can you translate options? A good, better, and a best. This is really important. Now, here's where we get into trouble, and that's why there's an asterisk right here. The third thing is providing the care. So just because you understand the patient and you're a great communicator and you translate options and you can see everything, my question to you, and you're the only one that knows this, is can you provide all of the care that you recommend? And if you can't provide the care, do you refer, right? Do you lean on the edge sometimes where you try stuff and you don't know if you can pull it off? Well, yellow light dentistry, I call it. That's not always bad, right? But the question is what is that litmus for you? But that is where we get into trouble. Some of us take on cases and treatment that when the patient accepts a lateral window sinus graft or a connective tissue graft or some type of augmentation, that we say we can do it, and we've done a few, and maybe we're not the people to do it. So those are the three things, and I think that ultimately, when we can pull off those three things and not be greedy about treatment, I think that we'll do very well. So let's now move it into a different direction and talk a little bit more about treatment itself. Now, one of the things I want to recommend to you is I'm going to now assume that you're here to talk about implant stuff, talk about some guided surgery, and I hope I've given you some things to think about. If we were going to take everything that I spoke about in a nutshell into one word, I want you to remember technology, okay? Because that's where it is. And we're gonna see a bigger boom tomorrow, okay? Now, patients like to touch, okay? So I would recommend that you at least have something for them to hold. So if you talk to them about a hybrid, or you talk to them about a zirconia bridge, or you talk to them about an overdenture, lots of people come in my office and think the implant is the tooth. So we can't underestimate someone's intelligence, both high and low, okay? So I just want to encourage you that if you have something tangible like what you see here in some form, it's very, very helpful, even if they're holding that while you're taking some pictures or you're getting them ready for a cone beam, and you're just showing them, hey, we're going to talk about this tonight. This is a guide. I want to show it to you. It's made for you. Or this is a hybrid, and I'm going to talk about that, and here's what it's going to do, and here's something that's removable. They like touching this stuff. So I would highly recommend that you have this. Maybe you even loan it to them to let them take it home, take a deposit and ask them to return it within a day or so. But something that they can hold and touch, it will be a way better value for them. All right. And by the way, if you want to know where to get them, there's several people that have stuff like that. But one, you can get all the guided stuff from 3D Diagnostics. They have plenty of guides, sample type guides, where they can get you those single, multiple, full arch guides. If you want models like of hybrids or anything like that, you can also call Salvin, S-A-L-V-I-N. If you tell them you saw me, they sometimes have institute discounts. You can ask for someone named Chris Toddy. Chris, and there's no financial vested interest in any of this for me. I'm just sharing with you guys. Chris Toddy is T-O-T-T-Y, and you can actually find him on Instagram. And if you want to get a model of a hybrid or something, he can help you. Good guy, good company. Okay, so let's take everything that we spoke about and show you a couple cases. And I picked a couple cool cases because I think I want to show you that the degree of difficulty in treatment doesn't change the approach that I started talking about a little bit earlier. So let's look at this, okay? All of these appointments were done in 2 visits. So imagine if you can go do something for someone tomorrow that they agree to pay $18 or $19 or $22,000 for, that you can accurately deliver if you have that surgical intellect, okay? That I don't know. In 2 appointments. I mean, that is COVID. That is COVID. Let's look. So I call this the one that got away. This is a patient of mine. His name is Kempit. Went to a doctor and a dentist, and the dentist looked in his mouth and said that he couldn't have implants in either spot, on number 19 or number 30, and basically sent him on his way. So he came in my office and he said, Dr. Engel, you know, I really don't want to destroy teeth. I really would like to talk to you about implants. Sure, let's talk about implants. He said, I would like 2 implants. I would prefer not to have bridges. Now, this guy's very young. And one of the things that I talk about in all the courses is you should have prejudices towards age. Now, not in the way you may think. Like if I ask a class, do you have prejudices towards age? Like, do you treatment plan according to age? And lo and behold, every single time I bring that up, somebody will raise their hand and I'll say, yes. They'll say, well, yeah, if someone's 90 years old, I'm going to do A, B, C, and D. And then everyone will shake their head like, yeah, me too. And I totally agree with that. I mean, if someone's 90 years old and they're in pain, you do palliative treatment, you get them comfortable, and that's it. Fine. No one brings up if they're young. So I say, well, what if they're young? And they look at me and I'm like, what if they're 29 and they just happen to be like this? Do you think a 3-unit bridge is the best thing for them? Because theoretically, we know by research that margins of a very, very, very well done bridge have their integrity for 7 years on average, okay? The aesthetics of them are up to 10 years. True aesthetics, like being very critical. So you're taking a 29-year-old person and you're cutting 4 teeth down, regardless if they have fillings or crowns, to then say, this is gonna last you 70 years or 50 years. It's just not gonna happen. So I encourage you and those attending my courses that if the patients are younger, you need to explain to them that my opinion is a bridge is not the best service for you. And here's why. You know, in 10 years, you're going to need to do something again. Or by the time you're 51, you're going to need to do something again. And that tooth in front is very small. And if we cut into it again a second time, you may even need a root canal on that too. So for whatever that's worth, I have a strong opinion on that, making dentistry last as long as we can. And in my opinion, if, you know, the best thing for a patient is their tooth, no question. I'm an implant guy, but I feel that's the best thing for them if the tooth is healthy and if the tooth is there, right? If not, my feeling is it's an implant. We want to keep everything a single tooth problem. Now, once you get into the frail, very elderly, yeah, then maybe surgery isn't the best thing. But anyway, so this guy came in, I think he was, like I said, 29, 30, 31 years old. I don't really remember. But anyway, I looked in his mouth and he said to me, this dentist said that I couldn't have implants. I wasn't a candidate for an implant. I said, okay. And I looked in his mouth and I said, yeah, well, that's a fair estimation, but I don't really know. I will tell you if I can see a 3D scan, because even though it looks this way on X-ray, a 3D scan might tell me something else. Now, it was very, very obvious that we knew that we needed to graft his right side. He had pocketing and he had a lot of vertical loss, and you can see that too between 28 and 30 or whatever that is on that side. But when I took the scan and I looked at 19, which is what you see here, okay? This is what the doctor saw in the mouth. And this is what precluded the doctor to tell Kempfit, you can't have an implant here. So Kempfit said, okay, well, I want an implant. And the doctor tried to encourage him to remove the amalgam, cut down the teeth. He said, that's not what I want to do. So call it the one that got away. So let's look at here. So I scan this patient, okay? Now let's look at these images. Okay, the axial image, for those of you who aren't sure about that, it's a plane that goes from inferior to superior, up and down. So what you're looking at right now, on your left side, where it gets very skinny. That's the very top of the ridge on the left side. At the top of the ridge, it's very thin. You can see that. If I drop down a little bit down towards the chin this way, I start to gain width. So now you can see on the upper right sagittal view, yeah, it's thin, and yeah, you have some buccal resorption, which is going to happen all the time if you don't have a tooth there, but that's kind of doable. That is kind of doable. So here we are at the height of the implant, and here we are about 1 millimeter down, we start getting some height. Okay. So I said, you know, actually, I think that we can do this. I'm going to get all of your information together, and we're going to do a Tele-dentistry conference, and I'm going to share something with you. And so we went on and we did this, what you see right now. And I said, Kemfit, the black and the white and the gray, that's your x-ray. The purple thing at the bottom, that's the model that we took when we dragged the camera around your mouth. And the pink fuchsia thing, that's the implant. And I want to tell you that while on your right side, we can't do this yet, we have to bone graft, and here's why. And I showed him it was thin, and I showed him it was short, and there was no matter of him trusting me, okay? Right now, the #1 reason that patients don't accept the treatment is doctors aren't giving them the value. Because I'll tell you right now, you have patients in your practice that you've told 20 times they need a root canal, and they've not done it, but they're still in your practice, so they like you. So what's the reasoning? Tell me, what is the reasoning for someone to go only to your practice but not do the treatment that you've elected them or told them that they should do? It's because they don't find a value in it. It doesn't hurt. They would rather buy a cruise to Alaska or a gold watch or whatever, right? So we have to show them. So when I showed Kemfit that his ridge was, you know, very short and very narrow in those terms, it wasn't about believing me. It was about, wow, this is the first time someone showed me this. Yes, I could see that I need a bone graft there. So it wasn't about believing me or not believing me. I was showing him interactively. So then we went to the other side, and I said, you know what? We actually can get an implant in on that other side, and I feel very good about it. And so I showed him, and he said, great, well, let's do it. Okay. So what I did was I designed an implant, a single implant, through the 3D Diagnostics website, which I'm sure you all have heard of or been there before. I've been working with 3D Diagnostics now for about 5 or 6 years. I've probably done about 600 to 800 cases with them. I would say at least 100 full arches a year. And I can tell you their guides are the best I've ever seen. And I'm not saying this because I told you I'm not vested in this. I'm just telling you that for someone who relies on guides to be what they need to be, I've worked with 3 different companies, and there's no one, in my opinion, that's even close. Anyway, so what you see here, I don't know if you could see the mouse, but I'm going to move it anyway. And if you can, that's good. In the top in the axial view, you could see the little blue circle. Okay. And that blue circle, if you can see it, is the top of the ridge where the top of the implant would be. And then if you look at your lower left, you see the sagittal view. So what you see there is you see a blue silhouette of a proposed implant site. You see the long axis or the drill in yellow, and then a tooth and a tooth form body, and then also a sleeve. So essentially this is the surgery. And then when we look at the transgential or the, oblique view, we can spin it around and make sure that we're fully housed in bone, etc. All right, so I'm showing this to Kemfit. Okay, so I'm not with him anymore. I'm doing with him what I'm doing with you. So imagine you were Kemfit. This is what I was doing. I showed him this. I said, this is the top of the ridge. We need to have 7 millimeters, which we have. This is the cross section of the arch. And the way that I explain this is you got to learn patient terms, guys. I say, so Kemfit, if you take a loaf of bread and you slice the loaf of bread and you turn it sideways, what do you see? He said, the white part. I said, exactly. This is the white part. It's the thickness. So I engaged them, involved them, made it individualized for him. Okay. So then what we did was we went ahead and we designed the guide. Now, this isn't about a whole guided surgery lecture, so to speak, but I'll just give you a couple basics. There's 2 files. We do what's called a dual scan protocol technique. Okay. And what that means is you need 2 scans. And when I first started this and, did one of the first ones in California many years ago, it was a lot more difficult. Guides were being made in Belgium. You would have to wait 3 weeks to get a guide. No one understood how to design it, so you had to learn it. You had to buy software that was 10 grand, and you had to do 3 scans. And we don't need to go over that now, but now we've eliminated 1 full scan. So now what we do is we do something called a dual scan technique. Many of you know this. 2 scans. 1 scan is the DICOM file, which is .dcm. That's your files of all your slices of your CBCT. That is 1. That is what we design safe implants in. The second file is a STL file. That's a stereolithography file. That is what we make the guide for or on. So that reproduces what is in the mouth, like the red thing here, or what will be in the mouth, maybe a denture to mimic that, right? So one is designed to make the guide. The other is there to safely place implants. And the reason that we do a merge with the two scans is so we can have the virtual and the analog, so to speak, the mouth and the x-ray, and put them together and put in safe implants based on anatomy that it's conducive for the prosthetic orientation of what we want. Okay, so here what you see is 3 windows. There's windows on each area to show me that I'm completely seated. And then away we go. So we created a small flap in this case, and the reason is and sometimes people don't think about this, and it's regardless of the fact that we're doing it guided or not, we still have to give some consideration to tissue. So we moved tissue out of the way. I did a lingual line angle incision. I moved the tissue over temporarily, and the reason for that, if you look on the right side, you could see that band of keratinization. That was on top of the ridge. On the buccal aspect of the ridge, all I had was the mucosa, the mobile tissue, which I'm a big proponent on moving it away. All of my implant cases, my focus is good bone and good attached tissue, period. So in this case, what I did was I moved it out of the way to place my implant, and then I would place a healing abutment if I got good torque on it, and I would reposition that tissue that you see right now on your right side on the buccal aspect of the healing abutment, so apical or buccal repositioning flap. Okay, now I put my guide on. Okay, and what I do is I drill and I just penetrate the cortical plate. I take an image of that. Why? Because if I'm working on a tooth-borne guide with teeth, I'm going to penetrate the plate, take an x-ray, takes 2 seconds, and make sure that I'm in line of fire, that the guide's not off, that I'm not going towards teeth. That's one thing that you can't fix. You can't fix a tooth that you have drilled into. I'm very, very happy to tell you in my career of doing guided surgery, a few thousand surgeries, I've never hit a tooth. And this is why. Because if I go in 2 millimeters, 3 millimeters, and I take an image, I know in my mind, worst case scenario, I'm buccal or facial palatal or perforated or whatever. I could fix that. We all could fix that. We can't fix a tooth that has a drill in it, okay? Then when I feel like, okay, we're safe, then I'll go to full depth and feel very comfortable about that. All right, so now I use an implant that is a 2.9 implant. It's the smallest implant on the market that is not a mini. A mini is anything over under 2.8 millimeters. So this is a traditional implant. This is a Straumann BLT, bone level tapered implant, and every millimeter helps. In cases like this, we have a prosthetic space of 7 millimeters, so it's going to be a small bicuspid. We'll clean up that amalgam and give him some more space. But anyway, it's a 2.9 implant, and we free-handed the implant after we did a pilot guide. Because a fully guided sleeve, which is 5 millimeters big, plus the acrylic to hold it would not fit down in that prosthetic space. Okay, so we put the implant in. I got decent torque, didn't love the torque. It was probably 20 to 25. So I felt I was just gonna bury it. So I put the tissue back, and here's a PA of the implant in. But better yet, here is a occlusal view of the tissue, and when the patient comes back to restore this case, I'll move the tissue out of the way as I just did, and then I'll put a healing abutment and train the tissue on the facial. But here's my post-op surgery, okay? I use the Vatex CBCT, and I just wanna mention that if you're using your CBCT to take post-op scans to check your angulation or to check your work, make sure that your machine is FDA approved for that. A lot of machines aren't. There are too much radiation, and the legislation considers it too much radiation for you to just check. So just make sure that you and your machine are allowed to do post-op scans on everything, which I do with my green CBCT. Okay, so here you are. You see the 2.9 implant in the sagittal view on the right. You see it in the axial view on the left. But if you look at this implant, it's pointing right towards the palatal cusp of the opposing molar. Now, the good part for me was when we compared it to the actual design, we were 12/1000th of a millimeter off, okay? It could look a little different because, you know, it's all relative to where you capture this picture you're looking at, forward or backward, the bone's going to change. But nevertheless, if you look at the lingual plate and the lingual plate, you can see it's pretty close. And so what I did was I used the 3D Diagnostics pilot guide and then freehanded the implant, okay? Hi, Bianchi. Okay, someone just raised their hand at me. Hopefully it's a hand and not a finger. Okay, so here is a 30-day, and the patient was really, really happy, and I was really, really happy. And again, this is 2 visits. But the great thing about this is now, if you think about COVID, and it's 8:15, so we started at 7. Yeah, so I'm going to end here in a few minutes. But when you think about COVID and you think about where you're going, how good is like something like this? Like, so small space, very easy if you're freehanding it to be off, having to correct, right? All of this time that you have to spend in the mouth with the blood, with the saliva, with the suction. And I'm sure that a lot of us can get a lot of really good results with this, but I chose to do this guided because I felt like I needed it in one specific spot. And I do trust my hands. I really do. But with the angulations that I was up against and the thin bone, et cetera, this was a tad of a challenge, right? I don't fear single implants. I just always want to do the best job prosthetically that I can. Okay, I'm going to zip through this case. This is pretty quick. I think it's only about 5 or 6 slides. And I do owe you an apology for this one because I couldn't find the pre-op. But I'll set it up and I'll tell you what it was. So this is Robbie. She came in and again, a 2-visit thing. She came in and she had 4 front teeth that were PFMs, and they were very, very bulky. She did look like a rabbit. She told me she felt like that she looked like a rabbit, and she did. They were very bulky, and she's had them for years, which really surprised me because they were just ugly. Anyway, so what I told her was that we could take out the teeth, which were just positioned really poorly, and they were periodontally involved. We could take out the teeth. We could place 2 lateral implants, and then do a lateral to lateral bridge. And she loved the idea. We did it over Tele-dentistry. And so here you go. So what I did here was I sectioned the lateral incisors. I don't think I sectioned, actually, they were individual crowns. So what I did was we planned this guide to sit on all of the teeth that you see, okay? So the first thing I had to do was take out the lateral incisors. Now it will make sense to all of us. So I took out the lateral incisors, and then I sat the guide, okay? So imagine 4 PFMs, ugly, periodontally involved, et cetera. So because the implants were going in the laterals, now we're gonna do immediate guided. Take out teeth, put implants in. Okay, so put the guide on, then we drill. All right, we do the same exact thing that we did before. On this one, you could see, if you look on the picture on the left and you see a bigger sleeve, that's a 5mm sleeve. So everything's gonna go through that because there was enough room to get that sleeve up in there between teeth. Okay, now what we did was, because we had sockets previously, before we placed the implants in, we were gonna put some graft in. I use 80-20 combo allograft. I get mine from Strongman. I love the product. It's something I use for everything. I use one graft material. Unless I'm trying to bulk out something aesthetically, then I'll use another product. But nevertheless, so what we're gonna do is we're gonna add a little bit of graft. This is after I drilled, and I only drilled with 1 drill. We're going to add a little bit of graft before we place our implants. And the reason that I'm going to do that is so it backfills the excess space. Okay, so here we go. Put the graft in, put the implant in, place the implant to the subscribed formula. So in this case, you can see the vertical hash lines on the driver, okay? So I stopped at the second line of hash lines. So there's one barrier that you can't see, that's the second one, and then the third one's 2 millimeters higher. So the recipe called for me stopping at the second line, which is what I did. And the reason this is important, I'll show you. Okay, as you can see, I torqued it in. I'm wearing black gloves. It's kind of an awkward looking photo, but anyway, I'm pulling, checking my torque, and I got 35 Newton on these implants. So what I immediately did was I took an impression and I poured it up and had my lab create a tissue model for me. And she had, because she had very bucky teeth, the bone was also bucky, meaning flared. For so many years, it shifted facial. So when we go to do the final, I have to really have angulated abutments. So what I did at the time of surgery was, you can see those gold pieces are what we call SRA abutments, screw retained abutments that are angled. So they angled back about 30 degrees. So it took the implant, put it right in bone, and then angled the implant abutment down 30 degrees. And then we added temp cylinders, okay? And from there, we made an immediate temporary. So you can see I sutured her up, pulled all the tissue in, put collagen plugs in 8 and 9 to bulk it out, which I use Aura plug. I get those from Salvin as well. And I sutured those passively, 8 and 9. I sutured 7 and 10 passively just to drag in the papilla a little bit, and made her an immediate 4-unit temporary, as you could see here. And then ultimately, this is 4 months later, okay? We took off that provisional and we went to a definitive provisional, okay? So now we're gonna this is a 2-step train. One is after surgery, and then the next one is to form the tissue. Now, I love this. This is when you take something off like this, this redness is, it's actually bleeding because you scratched the tissue, so to speak. So what we have is 7 and 10, and we have the silhouettes of 8 and 9 at 4 months, which I'm very happy with. And then at 5 months, we get custom abutments and the new temporary. So what you're looking at here is the new temporary. And what we're gonna do with the new temporary is we're gonna then fully train the tissue to drop into place. In another month or so, we will use those very same abutments, take a new impression, send the abutments back, and have them make a definitive 4-unit bridge on those abutments that contours to the appropriate shape. But what you're looking at here is you're looking at a 2-appointment process. 1, gather all the information, an STL file, a CBCT, and some photos. Have a discussion at night. She comes back in, and her dream of not having bucky teeth went away in 2 hours. Okay, now, can you do this freehand? I promise you I can, okay? But think of COVID. Think of prosthetically being right in the lateral incisors. If you're over a little, does that look like a lateral? Does it look like a central? Are you in the middle? Is there a prosthetic dilemma? I didn't have to worry about that here. It was all done for me, guided, finished. This procedure, the surgery took me 40 minutes, if that long. The prosthetic part of it, the pour up and everything, is another 30 to 40 minutes. So we're talking an hour and a half. The woman went from not being numb with bucky teeth to what you're looking at right now, or the first set of temporaries. Okay, I think you'll enjoy this. Let's end with this. It's a full arch case done in 2 appointments. And then I'm open to questions. I want to thank you very, very much for this time. I know it's a hard hour. It's a hard hour for me too. I came straight from home from surgery all day, and I haven't eaten either. So if you haven't eaten and you're hungry like me, thanks for hanging out. And if you are hanging out, that means it's interesting. So right on. Okay, this one, it's probably, you'll be able to probably find it somewhere if you find me, because I published this in Dentistry Today in March. And so if you get that magazine, or if you want to look online, you can download it. This whole case is in there with detailed explanations of what I've done. But anyway, I inherited this case. It's a gal who had an upper hybrid done that just wasn't done very well. And I'm not the kind of person that talks about other people and other people's dentistry. I really am not. This was just not done well. And I say that because I had a battle. What do? Do I make a really good bottom and make it meet something that isn't even adequate? Or do I tell her that maybe we should redo everything? And that's what I did. I told her, you know, I thought that the dentist did a nice job. Very, very nice job. However, it's hindering my ability to change the bottom, because that dentist built that top to these bottoms that you see. And I said, the only way that this will work for you is if I make something on the lower that looks like your lower teeth, because that's the only thing that will fit against the top. So I had to redesign everything, and let me show you a little bit about it. This is 2 appointments. Okay, so here's the top. I'm gonna run through this real quick. This is an occlusal view of the lowers. Ground down everything, okay? This person wasn't wearing a night guard. She had had the hybrid done on the top. When I say hybrid, I'm talking about a titanium bar with an acrylic wrap that was beat to crap. It was chipping, it was falling apart. I mean, the thing was broken, and she'd only had it 10 months and spent 25 grand. Okay, so here's her occlusal view. All right, so here's her plane of occlusion. Here's the new wax up that I did. This is what I wanted her teeth to look like. Now, this is all virtual, okay? All I have done is taken a CBCT and some impressions with an intraoral camera. That's it, and some photos, okay? Remember the 11 minutes. All right, so here's her new plane of occlusion. Okay, now what we could do is we could design implants to support that occlusion as you see it. There's no guesswork. And I explained this to her, and they went from not having money to doing the case, literally as soon as we presented this. So what you're looking at here is when we talk about bone reduction, and I teach those classes, and all the attendees get to do a full arch live of bone reduction, everything. You can go check it out. They're very cool, and no one else is doing that kind of a course here. Everything is designed based on where the teeth edges are. That's how we teach you to do this. So you first have to know where the teeth are. Where's the edge of the teeth? Where's the incisal occlusal plane of the teeth? How big are those teeth, right? How much space do you need for your material? Let's look. Okay, so let's look at this. So we take out her teeth, all of her teeth. I use something called the cube, that Acteon makes the cube. I'm very, very, very careful about how I take teeth out. The reason that you see this little light bulb guy, it's because this is a pearl. We all get excited about full arch surgery. Be very, very, very careful, because when you see teeth that are ground down like this, guys, that typically means the bone is very dense. They could be ankylosed. It's just like ortho, Wolff's Law, right? Bone moves when teeth move, and sometimes they're harder to get out. And the reason I say be really careful is because we need the buckle. We need the buckle shelf here to support our prosthetics. Okay, so here's all the teeth removed and a fairly aggressive flap. Now, this is something you have to get used to. You have to get used to exposing mental fragments. We do all of this in the classes. Now, what we do is we start with a guide. We put a guide on the teeth, and we create 4 what's called pin positioning holes before we take out any teeth. And those holes are going to be used through the whole surgery. So you could see these arrows, they're pointing to those holes. I didn't allude to them in the last slide, I apologize. But you have to get that right. Now, here's where anybody who's new at this goes wrong, 100%. On your right, that's an aggressive flap. Why isn't she bleeding that much? Because I've cut in keratinized attached tissue and slowly orange peeled the tissue away, okay? Know where your anatomy is and just be really cautious and do this. Now, what happens is when people are beginning to do this kind of stuff, they get very timid on flaps, and they push down the guide, and the guide has a little rock, and they force it down. This is hell in a handbag, guys, because if your first guide doesn't fit passively, nothing will work. So flap, 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 flap. If you don't know how to flap, come learn, I'll teach you. Okay, so we clean out everything. Let's get to it. Okay, so now this is called a bone reduction guide, okay? And again, we do all of this in mentoring 4. We're gonna put that bone reduction guide down, tissue's out of the way, it's displaced. The anchor pins are pushed in the original holes that you've created. So again, patient comes in with teeth, the first thing you're gonna do is put a pin positioning guide on. It's like a night guard, and it's got 4 holes in it. You just make your 4 holes, and that is your pin position for the whole surgery. Now what we're gonna do is we're going to flatten the bone at that level, okay? And we're gonna just smooth this down, okay? Nice and smooth. No rush, just do it really, really smooth. Artistry, okay? And then what we're gonna do is we're gonna get it like that, nice and smooth. And then the next thing that's gonna go on is a implant guide, okay? You see that black line? Let's try to go backwards. Watch the image on the left. You're gonna see a black line move right here. That line has to be completely shut, no open margins. If that's open or rocking, your implants will not go in straight. That means the bone reduction has to be smooth. Here's the implant guide down. If you could see my mouse, these are little kind of switches that go down. I don't really know what you call them, but they kind of drop down and turn to lock the guide into place. Okay, then what we're gonna do is we are gonna be given a surgical strategy towards placing these implants. Everything is guided, everything goes into place. Okay, so here are 5 implants placed on the lower. I'm a fan of 6 on the top and 5 on the bottom. That's my general go-to, especially if it's a composite defect, meaning we're replacing bone and gums. I see questions coming in, and I'll stick around for you guys. And again, you can Instagram me. Okay, once you get your implants into bone, okay, the next thing you're gonna do is put on this thing called an abutment guide. Now, the green lines indicate if there's an angle or a tilt to increase AP spread, you have to compensate that. Okay, so what you're looking at here is very, very, very important. So if you're just starting out with this, please listen to this. Please. What you're looking at next to that black arrow in the right, that is called your prosthetic screw. That thing sticking straight up is meant for 2 reasons. One, it is your carrier that you bring your abutment over to the mouth with. 2, that is your indicator of how your prosthetic screw is going to go in, and we want that as straight up and down as possible. This is your driver. That is what you're going to tighten your first screw to the implant to overcompensate for that angulation. So if you look at that driver, that is the angle that my implant is in. To get something to draw, we have to correct the angulation with a prosthetic screw. Now, here's the key. Anything going into the implants, get torqued, okay? Get torqued once and done. You have to check with your implant manufacturer. For Straumann, it's 35. So I torque that abutment at 35 and I don't touch it again. That is the abutment screw. Anything that is screwing the abutment to the implant gets torqued. Anything that screws the teeth to the abutment, hand tighten only. Those screws are only meant to be 10 to 15 Newton. If you torque them, you will break them. Okay, there's the carrier. Okay, 17 degrees, I chose in this case, and moving right along. Now, here's the abutment guide. The abutments are in. So as you can see right here, the green lines were provided by 3D Diagnostics for me. They say your abutment screw should be facing this direction. And as you can see in the blue circles, they are. If there's no green line, then that means it's a 0. It just goes straight in anyway. Lots of times in the anterior, you have to tip because of the angulation of the jaw. And here are the abutments, and it's showing you the emergence profile of what they look like. It's kind of hard to see in a flat image. Okay, and then ultimately, the cylinders are going to go on. And if you look at the planned angulation, as you see here, of number 27 or 28 or 29, it's tilted lingual, just like the design. If you look at the design, you could see that that one is tipping lingual. Why? Well, because maybe prosthetically it needed to be that way. Okay. And then what we're going to do is we're going to provide a PMMA and have her bite in the original bite. And you can see that's her prosthesis that was made for her 10 months ago on the top. And then what we're going to do is we're going to fill them as she's closed. Okay. And then backfill them. And there is her PMMA. It's an awkward looking shot in a mirror. She doesn't have 10 implants or 12 implants. Okay. But anyway, so this is her PMMA finished off in the lab. Okay. And then ultimately her final PMMA. Okay. So we're building her up, and then we're going to change the occlusion on the top. But this is one appointment, what you're looking at. This all happened one appointment. I do IV sedation. So this patient's sedated. It takes me about an hour and 15 minutes to do the surgery and about another hour and a half to an hour and 45 to do the prosthetics. But you're talking about a meet and greet, a get on a tele-dentistry call, and then the next appointment is this. And she leaves with those on. Okay, this is 4 months later. She comes back. Her implants are beautiful, right where I want them. Look at the tissue. Gorgeous keratinization. Those are the abutments that we put on at time of surgery, okay? Those weren't changed. So we're gonna take an impression now. As you can see, the bone heights are really good. Verify all the impression copings down. Everything looks good. All 5 implants are really good. The cylinders are on for the impression. We're gonna create a jig, in-house jig, as you see in the upper left. Then we're gonna take an impression and we're gonna have a definitive PMMA made, which you could see here. So now her lower is established. Now we had to fix her midline a little bit because the top was off. Now we're gonna go back and we are going to fix the top, keeping the bottom in a PMMA. And then ultimately when that's done, we'll transition her into 2 zirconia bridges. Okay, so here's the PMMA, the final, and there's her final PMMA in the mouth. And Tanisha is very, very, very happy. So the reason that we're doing the top, it was the midline, there was a lot of canting, there was a little bit of a reverse curvature in the smile, and there was also the thickness of that hybrid was about 9 to 10 millimeters, and she had fractured the back of it. So that is one appointment. All right, so we are exactly at 90 minutes, just under. I want to thank you for a few things. Number one, supporting me and letting me do what I love to do. And I hope you learned a few things. I hope that I was able to influence you to do something differently, or be excited about something differently. I love what I do. I love the people that I do it with and do it for. I want to leave it a better place. That's what I'm here to do. I love dentistry. I love surgery, and I love teaching. So thank you for being here. The few hundred that were here let me do what I love to do. So thank you. I put this slide up really quick because I wanted to remind you again, I'm not vested in this company. I'm just sharing something with you. When we all get back, there's going to be a mad rush for gear. Okay. 3D Diagnostics does have a store, shop.3ddx.com. And I personally just went and bought stuff there because they are very, very, very well priced. N95s, which are the real ones, and they have the KN95s, which are from China, that are not in industrial allowed, so to speak, but you certainly can buy them to wear them as masks. But they have the true real KN95s. They also have shields and a bunch of other things, and they don't go through a supplier, so they'll be able to ship right to you, and they are actually really quite reasonable. I just spent $1,000 before I got on here, so they gotta love me too. But they do have it, and they could ship right away. I just found out that my masks are going out tomorrow. So that's there for you. Go check it out. I don't want you to be stuck not being able to work because you don't have masks. If that works for you, that's great. Shop3ddx.com right there. So let's just regroup real quick. So we talked about the doctor considerations. We talked about 11-minute appointments. We talked about get your SBA stuff figured out, get your staff stuff figured out, get the technology thing figured out, and go to work and kick ass. Really, just go and be awesome. Okay, we talked about the patient considerations. Okay, what are those? We don't know. We really don't know. I've been pleasantly surprised. All the patients that come into my office have a mask in their hand and they look at me like, what do you think? And I'm like, well, if we don't have aerosols going around, you do what you want to do. But we don't know. So my recommendation is plan to be different, plan to keep them safe, do things to let them know that you care for their safety. We have put, if this helps you, we've put a table by the front door that has sterile pump and hand wipes and stuff as they come in. We put a couple stickers on the floor that said, hey, stay 6 feet back from the checkout desk. Just little things like that. Just so do some things to be obvious, right? So they know that you're trying. And then lastly, the practice considerations. Think about, how are you going to change when you go back? What is it that you're going to do? How are you going to be different? Are you looking at me going, wow, this guy's different. Some of the things he does are different. Be creative. Copy what I've said. Do what I do. I wish you would. Okay. That being said, again, one last time, if you want to get a hold of me, that's where you can get a hold of me. I always respond, and just give me a day or so. That's all I ask, because if you text me and you're in Zimbabwe and I'm doing surgery, I just need a little time. And with that, thank you for letting me do what I love to do, truly. Engelinstitute.com if you want to come and take courses with me. They're a blast. They're incredible. I love them, and we have a lot of fun. They're small and intimate, and we have a great time. Other than that, I would just like to thank 3D Diagnostics once again. And even though I'm hungry, I'm here for questions. And I saw a lot of hands going up, waving at me. And so thank you. I didn't have my chat on. I never do, because I don't want to be sidetracked by chat. So if you're asking me something or saying hello or something, and I didn't answer you, I'm not a butt, okay? I just am very into focusing on what I'm talking about. So I will go back and I will look at all that stuff, and I will reply. So guys, in closing, I'm going to hand it back to Frank, but before I leave kind of, I just wish each of you the best. Honestly, I really do. I wish all of you the best. I wish you the skill set right now to be different, to find a way to just make your patients fall in love with you all over again and be the best success that you can. Be humble, remember what we had and remember what we lost, and put that into every patient every day. Take care. Thank you.
Thank you, Dr. Engel, for the great lecture. That was very, very interesting. Now, before jumping to Q&A, a quick reminder for everyone, for your CE credit, please go to www.3ddx.com/CE and fill out the survey to get your credit. Again, it's www.3ddx.com/CE. And now to some questions. All right, so regarding the slide with the picture of the people on the beach in Florida, someone did ask, how about the other group that will think we are crazy, taking it too seriously? What do you think about that, Dr. Engel?
Yeah, I think it's a great question, and here's the thing, you know, when I look at our industry, whether, you know, I'm not a big social media guy, I never have been. I've really enjoyed Instagram a lot lately because I stick with the dental people, and I stick with the people that are very positive and compliment each other, and, you know, all that stuff. But when I'm on, what I see is, you know, I see a lot of dentists that are dressed up, you know, in my opinion, a little bit over the top. That's just my opinion, okay? I mean, it's mask upon mask upon mask upon mask. And while I'm all about protecting myself and protecting my patients, you know, I mean, when I was in dental school, I finished all my requirements about almost a year early, and I went into an HIV division ward. I went to school in San Francisco, and so anyone who lived in San Francisco who was HIV/AIDS positive got work done at the dental school free, and who was a resident there in San Francisco. And so I always learned to protect myself. Like all of you are going, yeah. We learn to protect ourselves from things like that, right? Now, the thing about this that's new, obviously, it's a virus, and there's a lot of ways that apparently that we can get it. But my point is this: I think that it's much like any position in politics or religion or anything. I think that you got to find a happy medium when it comes to other people, because I think that if you impose too much will either way on somebody, I don't think it'll be good for you. Meaning, if you're really casual, there's people that won't like that. If you're way over the top, they might think it's ridiculous. But I would err that way. I would, because I would rather someone think that I'm ridiculous, but still like me enough to come because I'm wearing 2 extra layers, versus me walking in and me hugging everybody and shaking everyone's hand and telling them, you know, you don't need to wear a mask in here. I don't think we should be aloof, but I don't think that there's going to be many people that think you're crazy. I think it's a great question. And the interesting part about that question is we don't know. So what am I doing? I'll tell you what I'm doing. And here's something for all of you. The first thing is we went to, I don't know, Target or something, and I bought a $60 shoe rack for 50 pairs of shoes. And it's at our back door. And the team, we have about 14 of us, they are not allowed to wear the same shoes in and out. So in other words, we all leave a pair of shoes at the rack. And when we come in the morning, we take our street shoes off, we put our work shoes on, and we go about our day. And then on the way out, we leave our work shoes and take our home shoes. So we're doing that for the team. And then as far as procedures, if it's a non-aerosol procedure, if I'm meeting somebody, I wear kind of like a cool mask, like a cloth black mask that shows them that I'm protecting myself, but I'm not wearing a blue medical mask. So it's like, oh, that's a fashion statement, right? So to speak, but it's just a black mask. And then when I sit down with them, I take it off and say, I'm comfortable speaking to you with my mask off. If you're comfortable, if you would like to wear masks, I'm fine with that. And so that's what we do. Now, anything that involves any kind of work, right? Then what we're gonna do is I wear scrubs, I work in scrubs, and I wear surgical gloves. I'm going to wear a mask and a shield and a disposable gown. And I do not leave the operatory. If I have to leave the operatory, I take obviously my surgical gloves off, my disposable gown off, and it's just me. And I walk out and I walk back in and I wash and I re-glove and I put on a disposable gown. And I really feel like I feel like that's sufficient for me. And I feel like the patients look at me and go, okay, he's got a couple layers on and he's changing his gown and it's a one and done gown. And I think that's good. I really do. That's just my opinion. And so if you feel like you want to wear N95s all the time and you want to wear a shield on top of your N95 or you want to print a mask or whatever, go for it. That's kind of my take. That's what I do.
Thank you, Dr. Engel. Do you have a reasonably priced intraoral scanner that you recommend that can also be used for Invisalign and implants and regular crown and bridge?
Yeah. So, reasonable is a funny word, and I don't mean to be mean, but my recommendation is I love the 3-shape scanner. I love the 3-shape scanner. Labs love the 3-shape scanner. There's a few top 3 that they love, but you always hear labs say that that's one of them. And there's a few, right? I'm just saying that being that I was asked the question, the 3-shape just is very versatile, and the image quality and the file quality, labs love it. So I highly recommend that you take a peek at that one.
All right. Do you make your PMMA in your office?
Yeah. So we do PMMAs. We have a printer and a milling unit, and and 2 lab techs in the office because that's all I do. And so I was outsourcing it for a while. And then it's not so much a cost prohibitive thing. It really probably cost me more when it's all said and done because of lab labor. But for me, it was more the convenience of getting so much done in one appointment. So yes, 3D Diagnostics has some really cool printers. So if you're looking into printing temporaries or printing night guards or anything like that, the printers that they have are very, very well priced. I mean, they're under $3,000 or $4,000, and you can print for days, and you could buy a PMMA puck for anywhere from $100 to a couple $100 and make a very nice temporary. So check it out. You can look on their site. If I think that they're on there. Frank, do you know, are the printers on there? Or?
They are on the website. I'm not quite sure what the prices are, yeah. But I'll let Alex shoot everyone an email.
I wasn't sure if that was the question because I know it was, hey, do I do that in my office? The answer is yes. And in order to do that, you got to have a printer, right? And so, yeah.
All right. When do you place 80/20 allografts in the socket space prior to implant placement? In other words, are you completing the sequence through the tap drill, then graft, then implant, or what's your sequence?
Yeah. Good question. So I finish all my drilling. Whatever drilling I'm going to do, I do that prior to grafting. Grafting goes in right before titanium. What determines if I do that is I look at the orifice of the socket, and I basically, decide by shape what kind of space will I have. If the space is 1 millimeter or less between the wall and the implant, I don't graft. If I feel like, after I put an implant in, man, I could have grafted. It's a little bit bigger than a millimeter. I'll just take an Aura plug, which is a collagen sponge. They're awesome. And I'll just smush it with my fingers like flat, and I'll stick it right over the top of the implant and do a figure 8 suture or a horizontal mattress, and it'll hold it in there quite nicely.
Alrighty.
If the orifice is bigger than 1.5 millimeters, so if I measure the orifice of number 8 and it's 9 millimeters and I'm putting a 4.5 millimeter implant in, then that's going to, tell me that I need to add graft. So I added a little bit, and you don't want to pack it too hard because then the implant will fight to get in that little pilot hole space way down at the bottom. So just put some inside, don't push it down. The implant will reverse up. The implant, when it goes in, will reverse the graft upward, and you'll see it'll feel really nice.
Thank you. Speaking of grafts, which allograft do you recommend?
Yeah, so it's a great question, and I'm going to give you the short answer, but I will tell you that my game 10 or 12 years ago really upped big time when I really understood tissue and grafting. It is the most brilliant thing. That is the cosmetic plastic surgery of the mouth, without question. So please apply yourself. And we have a great grafting course where we all work on live patients with PRP, PRF, sinus stuff, live extractions. I'm happy to teach you. Is that a plug? It is, because it's a great class. But to answer your question, I'm going to use, when do I use it? Was that the question, Frank?
No, which allograft would you recommend in general?
Yeah, so I use the 80-20 blend, cortical cancellous blend, and that for me is used all the time, with one exception. If I need something that's slow resorbing, so if I have a big space, for instance, that I'm not going to put an implant in, you can put a xenograft material in because it's going to stick around a lot longer. It's going to give you body, and it's going to give you cosmetic and a plastic surgery kind of thing. So sometimes what I'll do if I have a big defect is I will put the implant in, I'll put 80-20 around the threads of the implant and around the space, and then on top of that, I'll put some xenograft and a membrane. And the reason for that is because the xenograft is going to stick around a long time. A lot of it sticks around 3-4 times longer than the allograft does. So if you want bulk and you want it to stay around a while, then the xenograft is the way to go. If you're doing a socket graft with a 4-wall defect, meaning all your 4 walls are there and you want to get back to an implant soon, then you want something that resorbs quick, I would go with the allograft.
Thank you. We have a pretty long question. So in the case where you planned missing number 19, and the space was pretty tight.
Yeah.
So there is not enough or sufficient space that you need to restore number 19. So you have to gain space for path of insertion, restoring 18. In other words, when would you consider ortho treatment or a crowning number 19 to open up, or crowning, number 18 to open up space for a molar-sized crown instead of restoring a molar with a bicuspid-sized crown?
Yeah, that's a very good question. So about 43 or 44 GPs refer to me to do their implants. And that case landed in my lap. So lots of times I have to act like the specialist and not really get in the dentist's way of what he or she has planned to do with that patient. They come to me for an implant, and then they go back out. In the case of Kempfit, he had a dentist, but the dentist didn't want to do an implant, wanted to do a bridge. So that's when he came to me. So I had to be very careful on not ruining that relationship or making that other dentist look like he did something incorrectly. So what I said to the patient was, tell me what you have discussed with the doctor. And they spoke ortho. Okay. And so I'm answering your question at the same time. If this patient came to me for the first time, that would absolutely be a consideration. Would you like to stand that tooth up? Now, it wasn't that bad. So he did not want ortho, didn't want to spend the money on it, didn't want to go through the time, but it was a great question on your part. Yes, we're going to always ask them if they want to upright teeth. 2, I'm not so stuck on the number of the tooth or what it's supposed to be, right? So for instance, yes, it's number 19, and we all think of, well, that's a molar. Well, not necessarily. 19 only tells me where it is. It's on the patient's lower left, right? So if they have 7 millimeters of space, which is the minimum for me, absolute minimum, I won't give them an implant if it's something smaller, because I will tell them the crown is the investment with all the money. It's not even worth it. Let's figure out something else, right? Because you put an implant in, you put an abutment in, you put a 6 or a 5 millimeter crown in, and it just looks terrible. And they've spent $3,000, $4,000. So I do everything that I can to deter them from that. This particular case, he had just about 7. What I noticed on the amalgam on number 18 was it's very rough and it had an overhang. So I told him I was going to polish it down, and we did, and we gained probably 3/4 of a millimeter there. So he had 7+ millimeters. Now, what I told him was, the good news was he had a 4 extraction for ortho when he was younger, so he only had 1 bicuspid. So even though it was in the 19th position, I can give him a bicuspid and make it look like a second bicuspid, so it wasn't odd. Now, in a case where you have number 20 and 21, and they're really missing 19 and it's small, one of the options is, well, you have 7 millimeters there or 8 millimeters there. It's not a normal size molar. If you don't want to do ortho, we can do a tooth there, but keep in mind that it's going to be small. And they're like, okay. And I say, oh, okay, but just remember that you're going to have 3 teeth that look exactly the same. You're going to have 3 bicuspids, and that's not what we'd call normal. So when you look, you're going to look like you have 3 of the same teeth. If you're okay with that, then we could do that. It's far enough back where you probably wouldn't notice, but I want to be honest with you. So the question that you posed is great. That's very studious of you, and give them options and let them make the decision. But yeah, all that stuff is good. They will get an uprighting question. They will get a space question. They will get a, hey, this should be 10 millimeters. What would you like to do? All of that. But here's the thing. With that all being said, being that expert diagnostician and going through all those things, that was a great question. Where do you draw the line? Right? So if a patient has a 5 millimeter space and a bicuspid or a canine, they're like, I want an implant here. I'm like, I don't know that I'm your guy, to be honest with you, because I can't make this look good. And to me, it's much more than just getting paid. I want it to look good, and I just don't think it's going to look good. So anyway, I don't mean to drag the whole thing out. Your question was great, and it was a good one. So thank you.
Thank you, Dr. Engel. As the GP, do you make any lateral approach sinus lifts or soft tissue surgeries?
Yeah, I do many soft tissue surgeries. I enjoy them. That for me is the real beauty behind the case. I think we could make really nice implants. Really nice crowns if you have a good lab. No one can see your implants, hopefully, so that doesn't really matter as long as you have done it right and it's in the correct prosthetic position. I think the real difference between people who do implants pretty well versus people who do implants that look indistinguishable, like they look like teeth, is absolutely tissue. So yes, I do soft tissue procedures. I do a lot of PRF. I do, a lot of sticky bone stuff. And I also do connective tissue stuff. And I love it. As far as lateral windows, I've done them. I occasionally do them. I just really don't enjoy them, to be honest with you. I think for me, I don't know how to explain it other than I'm not turned on to them. I just don't love doing them. I have done them. I have been successful at them. I've also blown a couple open, which I didn't enjoy. So I just like doing what I love. And if I don't love it, I don't do it. Because my feeling is if you love what you do, you're going to keep wanting to get better at it. If you don't love what you're doing, you just want to get it over with. And that's not the procedure that you want to just get over with, because it's a very, very tenacious, disciplined procedure. So enter cautiously.
Thank you, sir. Another quick question. What is the best way to position the sensor for the PA radiograph with a 2 millimeter twist drill in place?
So there's a couple ways that you can do this. So first of all, you always want the sensor tangent to the source. So when we do our classes, I always preach good x-rays because it tells you everything. The angle, I'm Dr. Engel, that's funny. So you always want the beam tangent to the source. All right, so if this is the implant, this is the source, the cone. or the handheld, whatever you're using, and you want to try to get a tooth in front and a tooth in back. You want all, even if it's half a tooth, you want it tangent. Now the question is, I know what you're saying, how do you do that with a burr in? Well, what you could do is you can actually take your RIN holder and you can drill a hole in it. And you slide down over the drill, take the patient's hand and just ask the patient just to hold it in place and then just snap it. Wow. You owe me.
So one final question for the sake of time. What is your view on short implants? It's not going to be a short answer though.
Yeah, no pun intended. So here's my feeling. I'm a believer in a 2-to-1 ratio. That's just me. So if I have a tooth that's 6, 7, 8 millimeters tall, like a molar, I'm going to try to get a 10 or 12 in. If I'm restricted on height, I'd put in 1.5 million eighths, no problem. I'll give you a little trick here that maybe some of you might not know. When it comes to initial stability and an initial insertion of an implant, length helps, as you know. If you're doing an immediate implant, you want to get at least 2 millimeters into the native bone. It usually requires at least a 10, if not a 12, or some cases a 14 millimeter implant if you've got it. But here's the interesting thing. After implants integrate, it is well proven that nothing beyond 6 millimeters matters. So there's a couple new implants that Straumann's bringing out, and I'm going to jump on it. They're already doing 6s in Europe. So I'm quickly becoming a fan. I wouldn't use them in immediates, and I wouldn't go using them in soft bone. And if you do, soft bone's okay, just don't load them right away. But when length is for initial torque and stability, period. After 4 months, if the implant's integrated and the bone is where it's supposed to be, 6.1 millimeters to 49 millimeters, doesn't matter. It's the top 6 millimeters. So 8s I'm cool with. And I'm going to be cool with 6s too. And a lot of it depends on, do they bite with them? So in other words, if I'm putting in a lateral incisor number 7, I have no problem putting in an 8 millimeter implant, because it takes tensile forces. You bite, you're done. Whereas the back is compressive forces, which takes the heat of everything, as we know, and that's why people lose first molars first, right? Cool.
Well, thank you very much, Dr. Engel. Again, thank you so much for the outstanding presentation. Always a pleasure to have you here, and have a good night.
And you too, Frank. Thank you guys at 3D Diagnostics. And for the 100 of you that are left, thank you guys too. Really, really appreciate your time. Thanks for letting me talk and do what I love to do. Have a great night. Get back, kick COVID's ass, make a ton of money, make a ton of people happy, and make a ton of beautiful restorations. Peace.